Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome everyone back to the podcast. Today I'm with Dr. Derek Steinbacher. He is a plastic surgeon practicing in Connecticut. Derek, thank you for joining us on the podcast.
Great. Thanks so much. Thanks for having me. I'm a plastic surgeon and an oral surgeon.
Awesome. This is going to be so fun. Well, just going off of that, can you kind of give us a little background on your training and your current practice setup?
Yeah, sounds good. I started in dental school at Penn and initially thought about orthodontics, but then shifted into being interested in oral surgery or maxillofacial surgery. So did training at Mass General and Harvard for oral maxillofacial surgery training. While I was there, there's a lot of interface with general surgery and plastic surgery and cleft and craniofacial. And so became interested in that and had a chance to meet Paul Manson, who's was the chief at Hopkins, and really has a special place in his heart for oral maxillofacial surgeons as well. So I went on and did training in plastic surgery there with a lot of craniofacial background. And then I was back at Penn doing a craniofacial, cleft and craniofacial fellowship at CHOP. And then from there, I went into academics at Yale, and I was recruited initially into the plastic surgery department. Where I was, a member of the cleft and craniofacial team, and then ended up sort of heading up and being the director of the cleft and craniofacial program. And, 3 or 4 years in, I also became the chief of oral maxillofacial surgery and oversaw a lot of the residency programs and growth and clinical research aspects related to oral surgery, and kind of tried to combine a lot of the plastic craniofacial, oral maxillofacial things together. I started a fellowship, had research fellowships and those kinds of things, and became full professor. And after 12 years, I pivoted and transitioned into my own private practice with a ambulatory surgery center, and I've been in this setting for the last 3.5 years or so, still with privileges at Yale and working with some of the residents, but it's a total autonomous kind of situation now.
What was the biggest adjustment transitioning from academic surgery into private practice?
Yeah, I think there was several, adjustments. And kind of during training, you sort of only see the academic side of things. I mean, there's always some ability to see different private practice setups and ambulatory setups, but sometimes, when you're in the academic sphere, that's kind of all you know or all you see, and you kind of almost begin to think that that's, the only way to do things or the main way to do things. But when you get into your own setup, having the ability to make decisions and be able to pivot on a dime and not have to, go through a lot of administrative layers to make changes, is one of the biggest positives, I think, and one of the main advantages to being in that type of setup. But yeah, there's different resources, and there's some positives and some negatives, obviously.
What, in your view, are some of the keys to successfully building and growing an orthognathic surgery practice?
Yeah, so I think I had the benefit of kind of doing that when I was at Yale and being involved in cleft and craniofacial. There's a lot of those patients and patient populations that require and benefit from orthognathic surgery from a syndromic perspective, from a cleft lip and palate perspective, and then sort of heading up the dental and oral surgery programs as well. That's really part and parcel to that training, and so oral maxillofacial surgery teaching. So, getting to know all the orthodontists in and around the state has been beneficial in my setting and perspective. I try to blend that in a unique way where it's not just about the occlusion or just kind of beginning and ending with the occlusion, but trying to think of this from a functional perspective for the airway, for the cleft lip and palate patient, and then, really from an aesthetic perspective too. So I think that draws a different sort of patient population than the traditional referral from orthodontist to surgeon, but now it's a lot of direct to consumer patients finding you looking for aesthetic results, or cleft patients finding you looking for your area of expertise and that type of thing.
Which, I mean, the question may be kind of like, which orthognathic cases are best suited for the ACS setting? I mean, what would you say to that?
Yeah, so probably taking a step back, the way I was trained and how most of orthognathic surgery is done in this country is all, in a hospital setting, and, with inpatient at least one night admitted into the hospital. And, this is probably going to that transition as well, thinking, can these procedures be done as an outpatient? And, there's several people in the oral surgery world that have been doing it in clinics and settings that are outside of the hospital for years. So I went and visited a few of them, and then, thinking of all the things that are necessary to try to do this in an outpatient setting. So it's an ambulatory surgery setting, and the patients are not admitted, but they're discharged home. And, most all of my cases are double jaw or double jaw genioplasty. So they're, a little more complicated. It's not just single jaw cases, but mostly double jaw genioplasty. And doing them in an outpatient setting, has a lot of benefits, but there's a lot of considerations to take as well, mostly related to anesthesia, mostly related to things like exparel and pain control, limiting narcotic, having close follow-up with these patients. But I think there's a lot of benefits in doing these in an ambulatory setting as well. And yeah, that's been really one of the hallmarks, and one of the things I've been seeking to do is really to try to do these efficiently, effectively, focusing on patient outcomes and patient satisfaction, doing this in the ambulatory surgery setting.
And I know, that you just have a lot of experience with orthognathic, but also with rhinoplasty and some of the other facial plastic stuff that goes along there. What are some of your, I guess, pearls of dealing with orthognathic surgery and rhinoplasty?
Yeah, so and we wrote a book about this a few years ago too, which I think also, speaking to your question about building these kinds of practices, we wrote a book called Aesthetic Orthognathic Surgery and Rhinoplasty. And just through the course of training and doing these procedures and thinking about facial aesthetics and thinking about the airway and how the nose changes after orthognathic, I mean, they're really pretty inextricably linked, the nose and the jaws. So
Yeah.
I started getting more and more interested in how does the nose change with the Lafort, both functionally, obviously, there's a lot of improvement, but sometimes aesthetically, things can worsen, things can be about the same, or things can sometimes improve, and sort of understanding that interface. And I think the important thing is being able to counsel patients, what's going to happen to the nose, because if you don't do that, it can be a big surprise, and their nose can change and widen and not look as good. But if you have the tools at your disposal to be able to address that with a rhinoplasty later, that's very positive. But I think the combination of both rhinoplasty and orthognathic is really some of the most powerful um, sets of techniques that we have in surgery to be able to optimize function, aesthetics, and really change the face and the facial balance. I think you're muted.
Sorry about that. I was just gonna say I have a dental colleague who's, in his 30s and needing orthognathic surgery, but he's happy with the position of his nose, and his nose is already just slightly upturned, and he's really worried that with an advancement, it would be more upturned and widen his alar base. I mean, how would you handle something kind of like that?
Yeah, so I think part of it is now that so much of the planning was with VSP and 3D planning and understanding, compared to model surgery when we train, when you're just looking at the teeth and you don't really have any reference points for the anterior nasal spine or the piriform, and the positioning of the bone underneath the nose. Now that we have a lot greater visibility of those structures, and when we're changing the occlusal plane, clockwise and counterclockwise, impacting or vertically lengthening, all of those things have a pretty big impact on the nose. So there's several things that I try to do that will try to preserve some of the appearance of the nose, which includes, when you do counterclockwise, there's a little less advancement at the piriform. If you can come underneath the anterior nasal spine, preserve that septal attachment to the nose, then that also prevents less splay and less change to the nose. Alar cinch can be beneficial, but more like a U stitch, um, can be beneficial. But in some cases, even with all of these techniques and interventions, the nose can change. And so it's important to try to counsel patients about that and have the ability to, alter that in the future if needed.
When do you prefer combining orthognathic surgery and rhinoplasty versus staging and doing one and then waiting and doing the other?
Yeah. That's a good question. And some patients want everything at once. And at the beginning, when I started doing these things, sometimes I would do them simultaneously. But there's a few challenges to that. Number one is you have a nasal tube in place for the orthognathic surgery, and then to do the rhinoplasty, you have to switch that out on, freshly operated jaws and have anesthesia manipulate again and put an oral tube. And number two, from a post-op recovery perspective, if you have Doyle splints in the nose and if you have elastics kind of holding maxillomandibular fixation, it could just make it uncomfortable, difficult to breathe when already the recovery from orthognathic, has that as a challenge. And then number three is what we're talking about with the pier form and kind of changing the base of the nose. I kind of like to have that settled and have kind of a stable, you really need a stable posterior septal angle, which is where the septum attaches to the intranasal spine, and to have that as stable as possible before doing the rhinoplasty, I think is ideal. So these days, I pretty much always stage them for those reasons, and I think that gets you the better result and more predictable result and better patient outcomes.
Yeah, I'm sure a lot of it too is hand holding and kind of giving them those expectations and let them know that it's a process and that why you'd stage it, all that type of stuff.
Yeah, absolutely.
What facial aesthetic principles do you think oral surgeons maybe could better understand or should better understand, given your background in plastics and oral surgery?
Yeah, I think, with the evolution of how we've planned orthognathic surgery has given a lot more information and fidelity and details of things. And like I was saying earlier, the way I trained and most of us trained is just with models, and you're really trying to the goal, it almost begins and ends with the occlusion. If I could just move the maxilla and give you a class one positive overbite overjet in the simplest way possible, then that's, kind of the treatment plan that should be pursued. But now I feel like we're more zoomed out, really everybody, craniofacial plastics, oral surgery, and we're looking at the whole face. We're looking up to the forehead. We're thinking about the airway. We're thinking about the TMJs. And now sort of the occlusion is the baseline. It's you set the occlusion, you set the head position, and then I'm thinking, where should the bones end up in space? Not just the teeth, but the bones, and how do we position those bones relative to glabella or to the forehead or to the malar region? Do we want to do more clockwise or counterclockwise to kind of change the taper of the face, V line, or giving you better chin projection depending on your airway goals or aesthetic goals. And so that's kind of more the end in sight, the light at the end of the tunnel is where should those bones end up, and the occlusion is much earlier on in the planning portion. So thinking of those balance, and there's some subjectivity to that too, though, because um, you know, some patients like a more projected chin, some want to maintain some femininity and not have that projected of a chin. And the same with some of the nasal changes in shape. Some patients are more keyed into their airway and just want to have their sleep apnea cured and never using CPAP again. So in those cases, we might, advance more than we otherwise would. So it's kind of a fine, delicate balance with the aesthetics, the function, and, the occlusion.
What is your like a kind of current approach to diagnosing and treating facial asymmetry and condylar hyperplasia?
Yeah, yeah. So this is a very interesting area to me because, it incorporates all of these elements. It takes into consideration the TMJ, the aesthetics, facial symmetry, the soft tissue, bone augmentation or reduction, and those kinds of things. And condylar hyperplasia, I think, is often underdiagnosed. And one of the main causes for facial asymmetry. And so, we wrote a paper a few years ago where we looked at cases where there's condylar hyperplasia and we just did orthognathic surgery, the upper lower jaw and chin without adjusting the TMJ length or without doing a high condylectomy versus, another series of patients that also had high condylectomy, regardless of whether it was active or inactive. Certainly, the standard of care, people talk about if it's active, you need to do a high condylectomy. If it's not active, then that's where kind of the gray zone comes. But what we found looking at some AI tools, looking at symmetry, is that you get much better symmetry when you do a high condylectomy. If there's a discrepancy of more than maybe 5 millimeters from the sigmoid to the top of the condyle on one side versus the other. And it makes sense because then the jaw angles are more even. It makes sense because, this is the only bone in the body where it's a single bone with two joints. And if you leave those unequal, and you have the same kind of muscle dimensions attached to that, one side's going to bear a little more of the brunt of the forces, and it's going to have a different position of the disc and those types of things. So to me, it makes sense to make both those ramus condyle unit lengths even, both from a functional perspective and and sort of the biomechanical perspective. So if there's condylar hyperplasia, our preferred treatment is a high condylectomy, upper lower jaw, 𝐏𝐸𝐢𝐬𝐤. In some cases, we may need to do some facial bone implants to help with that symmetry, and we do a lot of fat grafting as well to the smaller side of the face to help with symmetry.
Oh, that's great to hear. I mean, in your mind, what are some of the more common mistakes surgeons make when treating asymmetry or other complex orthognathic cases?
Yeah, I don't know about common mistakes necessarily, except for, I know a lot of people do try to not do a high condylectomy. And then, like I was saying, we end up still with some persistent asymmetry and end up still with having one side shorter than the other that, ends up causing a little more resorption on the opposite side or clicking and popping and those kinds of things. I see sometimes, like we're also saying earlier, that if the focus is on just moving one jaw, then sometimes the bones aren't ending up in the most ideal position. And that's why I like to, most of my cases are double jaw because we're really wanting to change the occlusal plane. We're really wanting to put the A point and the B point and the bones in the ideal position. But I think those are some of the main things.
So we have a large contingency of listeners that are oral surgery residents. What advice would you give to residents and young surgeons who just really enjoy doing orthognathic surgery and want to build a kind of a high level practice with orthognathic surgery?
Yeah, I think, just having a voracious appetite for learning and learning as much as you can, doing as many cases, even if it's just watching when you're sort of a, dental student or medical student or junior resident, trying to, if you could carve out that time to be in as many cases with as many different possible is really ideal. And then, a lot of these programs have ability to visit other people in other parts of the country or other parts of the world. And, I've done that even recently. Going to visit other surgeons is always very helpful and beneficial to see how other people do it. And, we have visitors come all the time. From other programs and other countries that are surgeons or residents, to see how we do it as well. And I think, that interchange is ideal, and reading as much as you can and being open and being open-minded about this is really the way to go.
Yeah, that's great advice. Really appreciate you sharing that. And this is, good stuff to talk to you about. You have so much experience in this realm. So, I mean, we're just kind of doing a surface overview here, but if there are listeners who have kind of further questions, would you be open to us maybe putting some of your contact information in the show notes?
Yeah, absolutely.
Okay. So we end every podcast with some rapid fire questions. So the first one is, what's the best book you've read in the past year?
Yeah, best book is maybe difficult to say exactly, but I've read this book. It's called The Autobiography of a Face by Lucy Greeley, who was a writer and poet and had a facial deformity as a kid, and it kind of describes her, some of the emotional and psychological stress and struggles that kind of went along with that, and the relationship that she had with another writer, Ann Patchett, was also documented in a book called Truth and Beauty. So I think, any of us that are interested in face and facial deformities and the impact beyond just kind of the structure and anatomy of it, it'd be interesting to read those as well as their relationship. I'm also starting to read this book about Van Gogh called A Fire in His Soul, where it talks about, his transition from, one site to moving to Paris, where he really started blossoming as a painter. So I'm just in the early stages of that book, but that's another one I might recommend.
Awesome. Yeah, those sound great. I need to read those. The next question is, what's the best or what's the most helpful kind of non-oral surgery thing you do in your life that helps you with your daily oral surgery skills? Is there anything that translates there?
Yeah, I mean, the traditionally, I've been really interested in music, and I'm percussionist and drummer, and I think that's good in multiple ways and kind of correlates to surgical abilities and training and thought processes and those kind of things. But it's also a good outlet, it's a different way of thinking, and it's nice to kind of get outside of the day to day by, playing the drums and playing in bands and those types of things. But yeah,
That is cool.
that's fun.
I can imagine if you're playing in a band, kind of like in a team setting, you're working together, it's probably not too unlike working in an oral surgery team with assistants and everyone who's involved in the whole operatory experience.
Exactly.
Next question, what forceps do you use to extract tooth number 12?
Yeah, so I still do some extractions, mostly in the, during orthognathic surgery, or I do a lot of cleft patients still, cleft lip and palate, but I don't have very many forceps on my set. I think we only have an upper universal, a lower universal, so I'm sure I would use the upper universal for that.
Sounds good. How about what's the best movie or TV series you've seen in the past year?
Yeah, I think there's been a lot of good sports on recently. I'm watching a lot of the World Cup, which is great, and the Winter Olympics was great, and basketball and hockey recently. But I've been watching that series Beef on Netflix, which they had a first season a couple of years ago, and now there's a second kind of unrelated season. But
Oh,
it's
nice.
a Korean director that's very good, very interesting.
Okay. It's a great rec. How about what's your favorite quote?
My favorite quote. I know I did hear somebody recently talk about Oscar Wilde say, be yourself because everyone else is taken. So that's probably that's probably what I try to live by.
Well, that's all I got for you. I really appreciate you humoring me and answering those questions. That's really great. Any other thoughts or comments you have for our listeners?
Yeah, no, I mean, I just think that the multidisciplinary, we're in this realm now of sort of hyper focus, and I go to meetings where people they just do rhinoplasty all the time, and then when they show the results, you see that there's a small chin, or they're not thinking of the whole face, or some orthognathic meetings, they ignore the nose, and I think blending these things together and thinking holistically, still being specialized, but thinking a little bit outside the box, I think is the way to go. And I think, with all the 3D tools and AI and things that we have and learning tools at our disposal, it's really exciting for the future of trainees and thinking what these fields have to offer.
Yeah, that's great advice. Well, I really appreciate you sharing and being willing to field questions if listeners have further questions. You just have a ton of experience, both in academic, private practice. You've done so many different things that I think you're a great resource to young surgeons trying to figure out what to do. So thanks for sharing with us today.
Awesome. Thanks so much.
Have a good rest of your day. Talk to you later.
Sounds good.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, 𝐏𝐸𝐢𝐬𝐐@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.